Okay, Chapter 16, continuing with Chapter 16, Part 2 of Chapter 16. We're going to finish up a little bit more on the assessment of the airways, and then in Part 3 we'll then move on to the treatment involved with airway management. All right, so during our primary assessment, the apparent unresponsive patient. If the airway contains fluid or blood or vomit, etc., suction it to clear it. Suction, I think, is highly underused in EMS in general. A lot of people don't like the sound of it. Of course, nobody likes to clean it up, and people just, I think, overthink it or overlook it. And suction is a very nice piece of equipment, and it can make a huge benefit in the patient's airway. Whether we're doing a manual suction device or a powered suction device, even in worst case scenarios, if we're turning the patient and we're wiping out their mouth, getting that stuff out of their airway instantly improves the ability to ventilate and potentially to oxygenate our patients. So suction, highly underused. Those of you guys who have not been around the EMS block for a couple of decades probably don't remember a time in which we had to clean the suction unit. We may have had a little liner bag in there that helped us clean it up a little bit, but in reality, the old time cleaning up of the suction was really disgusting. So today, to be able to take a disposable canister and throw that in the red biohazard bag, put a new disposable canister and new disposable tubing and whatnot in, that's actually pretty stinking nice compared to the way it certainly could be. So airway adjuncts, of course, are important. These are things that are done during primary assessment. We don't do a lot of treatment in primary assessment, but we do things like minor airway, or basic airway, I shouldn't say minor, basic airway management items, controlling of bleeding, CPR, AEDs. That's all basic primary assessment stuff. So we don't jump into King Airways. We're not looking at starting IVs or giving very many medications when we're talking about primary assessment, mainly because many of these things have to have a decent amount of assessment information done on them prior to us considering doing some of them. So if we didn't, we'll take for example some of the drugs that we may give. If we did not take a moment to get a history on it, particularly allergies and whatnot, or other medications that may be interfering or have interactions, we could potentially end up in a world of hurt. So that's where some of the treatments will certainly take a back seat to assessment. But this basic stuff, ABCs, saves your life and certainly can take your life, and that's where we have to draw that line in the sand. What is it that we can do quickly that will make a huge difference? So OPAs and NPAs. On the apparently unresponsive patient, we're also going to be looking, listening, feeling for air, looking for the chest rise and fall, listening for air movement, feeling air movement on our cheeks. If the breathing is inadequate or absent, then we need to jump to artificial ventilation of some sort. Whether we use a bag valve mask device, we use a oxygen-powered ventilatory device, or what a lot of people will call the demand valve, or even a pocket mask to begin ventilation. Ventilations that are obstructed, then we need to reposition the airway and attempt to help. If that doesn't help, then we suspect a foreign body airway obstruction. Most of the time, we relieve that airway obstruction by simply positioning the head. And if that doesn't take care of the situation, and we reposition, still don't get a decent airway, then we are going to consider whether we need to do abdominal thrusts, chest thrust, back blows, whatever, depending on the patient. With a responsive patient, though, we're going to look and listen to assess their airway. We're not going to get up in their face usually, but we're going to observe them from a few feet away, kind of watch to see how well they're moving air, and if they're struggling at all. We're going to look for significant signs of hypoxia, whether we've got decreasing levels of consciousness, or maybe they're just not as alert as normal. Do they show any indications of significant respiratory distress? This could include labored breathing, noisy respirations, maybe gasping. Maybe they have 2 or 3 word dyspnea. Perhaps they are weak and slumped over. So those are some other indications that are showing us that this person's not oxygenating well. So here's a good little table that helps us recall some of the signs of inadequate breathing. So increased work of breathing or the use of accessory muscles. So they look like they're working to breathe. Most of us, as we're sitting here watching this lecture, probably are doing this basically effortlessly. But if those people that have to work, they get the muscles up in their neck, across their chest, even sometimes into their abdomen, they get those going to improve their ability to ventilate. Noisy breathing. We've already touched on the sounds of stridor, snoring, gurgling, wheezing, and crackles, or rails, and we know that what those indicate. Decreased or absent air movement or breath sounds. Sometimes we listen to patients and we hear nothing or next to nothing as they continue to breathe. If this is the case, just because you don't hear crackles, rails, whatnot, doesn't mean everything's a-okay. Sometimes the patient is so tight and they are so overinflated with air, they're just not moving it. And therefore, with all this air trapped, they really don't have decent breath sounds at all. Apnea or respiratory arrest, that's kind of a no-brainer. Ventilatory rate less than 8 or greater than 30 per minute in an adult. Now, those numbers in and of themselves generally are not the only deciding factor that says inadequate breathing. They're strongly suggestive, and we have to look at the rest of the clinical presentation. An SpO2 of less than 95%, unless we have some other outlying factor like we're in a high altitude or something along those lines. Irregular breathing patterns and cyanosis. So, what are the 5 indicators of an airway obstruction? So the 5 indicators of an airway obstruction would be things such as their apneic, of course. The patient has little to no audible sounds, or they're unable to speak. In many cases, we also have the patient who is holding their hands to their throat, kind of the universal sign for choking. We also may have patients who have minimal air movement and causing some slight squeaks or squeals as they try to breathe as a sign of an incomplete airway obstruction. And then, of course, potentially the patient who is unresponsive could potentially also be a airway obstruction patient. So primary assessment, or clinical decision making, is going to be the goal of the primary assessment is to find and treat life threats. Or you can say it pretty like they say there, but I like the short version. The purpose of the primary assessment is to find and treat life threats, the things that are going to kill you right now. The best approach to managing a patient's airway moves from simple to complex. I think I've brought up in the past diving too quickly into a very advanced airway. Maybe it's the diabetic patient or the drug overdose that we give a medication to, and bam, they instantly wake up. That could potentially be a major issue if we have an advanced airway down their throat. So it's okay to start small and move up. If what you're doing isn't working, take the next step. So doing some clinical decision making. The topic of, or the concept of clinical decision making really is one of those that people are thinking about all the information at hand prior to just doing something. It hasn't been all that many years in which a lot of EMS providers really were just cookbook providers, where they were told, if this, do this. And I know I brought this up in the past, but let's take, for example, a person with chest pain. If we were to take a cookbook medicine approach to this, that patient with chest pain, we very well could be saying, okay, well, they have to have oxygen, they have to have nitro, and they have to have aspirin. No ifs, ands, or buts about it. When in reality, we may be dealing with a situation that the person has suffered a traumatic injury, or maybe they have a pulmonary embolus that causes some chest discomfort. So we know that there are other reasons why people get chest discomfort, and so by having reasonable clinical thinking, clinical decision-making abilities, we can then stop and consider what information we have at hand. This is by no means a scientific fact, but in many cases, cardiologists have been heard to say, well, if the patient's complaining of sharp chest pain, it's not cardiac related. There's not enough data to back that up, but it does tend to be a very, very common trend that you can start to say, okay, well, I've had this patient before with very similar signs or symptoms, and is it or is it not likely to be this, that, or the other thing? Sometimes we just don't know. So here's kind of a clinical decision-making tree for airway and ventilatory management. And you kind of have to, you're not probably going to memorize this, but what you should be able to do is then start to see some of the questions we have to ask. So our general impression of the responsiveness and level of distress. They're apparently unresponsive, checking breathing and pulse. We get to that very quickly in this whole process simply because we may need to get onto CPR, AED, that sort of thing. And if they are responsive, that's usually a little bit better sign that we can stop for a moment and do a better assessment, take a better, closer, and more in-depth look for our patient before we go running down a trail there. So if we have the responsive patient, we'll go that way quickly because that's the easier one. If we have the responsive patient, we're going to assess that quality of airway breathing and oxygenation. If we determine it to be inadequate, we assist with it and give supplemental O2. If we determine it to be adequate effort, an adequate exchange, then we look at the oxygenation. So if we can move the air in and out, how then is the level of the oxygen that we give this patient? If it is inadequate, we provide supplemental. If it's adequate, then we can consider. I mean, if we've got a person 99% no signs of shortness of breath, complaining of altered mental status, they may not need oxygen, particularly by non-rebreather. If we're unsure, we're uncomfortable, it's all right to give them a little bit, and if we're ever in doubt, treat, but this helps us start to make better decisions about our treatment. If we go down that unresponsive trail, we check breathing and pulse. So it can be really one of three things. No breathing, no pulse. We start chest compressions, go down the cardiac arrest trail. They have breathing and a pulse. We're going to check their responsiveness and attempt to see if we can get them to wake up. Pulse but no breathing, we need to establish an airway and then start ventilation. Obviously, ventilation is going to include oxygen. With the patient that is breathing and has a pulse, we check the responsiveness. If they're decreased, then we check the adequacy of their breathing and apply oxygen. If it's inadequate breathing, then we can ventilate and administer oxygen. If they're responsive, then we go to the assessment for the responsive patient. So this little tree kind of has, I mean, you could certainly add some arrows and kind of redirect people on this tree, but for the most part, it helps us kind of break it down into a couple of categories that we look at. So when a patient complains of dyspnea, impaired ventilation, or oxygenation, they generally must receive supplemental oxygen. So if they're complaining of shortness of breath, even though they may sat 98, 99% on room air, it's okay to put them on a few liters by cannula. Not only does this maybe potentially boost their oxygenation, but it also creates a placebo effect that we're doing something for them. I've even tried this with some patients where the patient had some complaint that really it didn't seem to jive with what they really were showing. But I put them on a nasal cannula and then didn't turn the bottle on just to see what kind of a reaction I got out of them. And I'd ask them in a minute or two later, so how's that oxygen? Oh, it's helping a lot. It's really, really helping me. And you know that I haven't done a stinking thing for them, but that peace of mind has helped to make them feel like they're getting better. So it changed their perception. So determine whether the patient is in or at risk for respiratory distress or respiratory failure. The patient may not be in respiratory distress at the moment. Could they potentially be? Could they be a patient who suffered, maybe it was a burn to their airway that happened just moments ago, and right now they're breathing okay, but do we have the potential for that to occur? Are they in respiratory distress or are they in respiratory failure? Respiratory failure is usually when, respiratory distress, they're ramping up, things are getting faster, things are getting harder, things are struggle. Respiratory failure is really to the point in which now they have decided, I am done. I have no more to give. I am shutting down. So usually respiratory rates dive, patient's altered mental status really dives, so that's usually the breaking point. Decreasing level of consciousness is a serious threat to the patency of an airway. So if we have a patient with an altered mental status and they start to vomit, are they able to turn their head and clear their own airway? Or is it something that we have to then start to think about? Well, the patient's mental status continues to go down. Do I now need to turn them up on their side, place them in a shock position, or on the backboard? Do I need to be prepared to get them tipped and suction? Things just to constantly be reassessing. So as we move on then to the secondary assessment, we're looking now for a specific respiratory rate and detecting any specific respiratory patterns. So initially when we do our primary assessment, or what we formerly call the initial assessment, but initially we're just looking, is it there and does it appear to be adequate? We're kind of gathering that rate, rhythm, quality, depth, whatnot, but we're not really quantifying it. So if we haven't up to this point, now a lot of times if we have multiple hands, we do go ahead and get vitals just immediately. If we haven't up to this point, then we make sure we get a formal set of vital signs, including an adult respiratory rate. Typical adult respiratory rate, 12 to 20. What we saw earlier on a slide that said signs of inadequate respiration are less than 8 or more than 30. And that's true. People sometimes fluctuate a little bit. Every person's different. Nobody reads the textbook. And so in those cases, if somebody's got a respiratory rate of 10, maybe they're a finely tuned athlete and do very well. Maybe they have a respiratory rate of 24, 26, 28. Maybe they have COPD and they always breathe that fast. So again, in and of itself, a single number doesn't give us the whole key. We also look at respiratory patterns. And these respiratory patterns that are represented here on the picture include eupnea, tachypnea, bradypnea, apnea, hyperypnea, Cheyne-Stokes respiration, Biot's respiration. It looks like Biot's, but it's appropriately pronounced Biot's. Kussmaul's respiration, and apneustic respiration. So to dive into that just a little bit more, eupnea means normal breathing. EU in front of anything generally means normal. Tachy and brady. Tachy specifically means fast, brady specifically means slow. So this has just to do with the rate. Apnea, when we stick an A in front of anything, it usually means lack of, so that would be lack of breathing. Hyper, on the other side of this. People confuse hyperapnea or hyperapnea and tachypnea. Hyperapnea is deep, but generally normal. So it's bigger than normal is hyper. Tachy is faster. Cheyne-Stokes. Cheyne-Stokes is a very gradual increase and then decrease pattern followed by periods of apnea. Very, very specific to people with brain issues. BOs. BOs is a rapid, deep, so there's kind of a combination there, rapid and deep. So we have tachypnea and hyperapnea, but then with short periods of pauses or apnea in between. Also typically a central nervous system issue. Kussmaul's is hyperapnea and tachypnea constantly, very heavy, very fast. And then apneustic is prolonged inspiratory phase, very shortened expiratory phase. A lot of times it's very unpredictable. So, and you can see the causes there. So tachypnea, usually fever, anxiety, exercise, shock, bradypnea, some drug overdoses, sleep, some metabolic disorders, some types of head injuries. Apnea, all kinds of different things. Deceased patient, essentially. Hyperapnea is emotional stress as well as diabetic ketoacidosis, although Kussmaul's is much more common in the diabetic ketoacidosis patient. I talked about Cheyne-Stokes and BOs being central nervous system issues, and then apneustic is also a lesion in the brainstem near the area, an injury basically, maybe from a medical issue, but an injury in the brainstem kind of knocks out the regulatory pattern of the respiratory center. Pulse oximetry. This pulse oximeter is a little bit older style pulse oximeter, one you would typically see in the hospitals. It's not very portable. However, pulse oximetry can be a great piece of equipment for us to use when we are assessing a patient's respiratory abilities. I've talked about this in the past, or in chapter actually 18, when we are referring to monitoring devices, and you'll hear a little bit more about pulse oximetry in that chapter. So secondary assessment and reassessment. We've performed now a detailed assessment of breath sounds. If we hadn't gathered them before, definitely is something we want to look at. If you're not familiar with the places you should be listening to breath sounds, you should take a good look at page 387 in your textbook, and that has a pretty good representation there. You want to be mid-clavicularly, or basically almost directly above the nipples, just a few finger widths below the collarbone. You also want to listen mid-axillary, or midway through their body or their armpit, almost directly over from where the nipple line should be, because we know sometimes those migrate. And then if you are listening to the back is also another great spot to listen. The thing to keep in mind is you need to stay off of the scapula or the collar or the shoulder blades. So you should listen around the outside edge, or I guess it technically would be the inside edge of the scapula, between the scapula and the spine. They're just showing you simply one spot there. You can listen 2 or 3 spots along the back there. So our detailed breath sounds. Pulse oximetry to assess our oxygen saturation. Of course, remember we're keeping that, taking that with a grain of salt. We're intending to have an SpO2 of 95% or higher when we're administering oxygen. If we have one already 95%, we may choose to forego oxygen and just kind of watch them a bit. Capnography, again, this is covered in more detail in chapter 18, but capnography tells us a bit about a patient and their exhaled gases, or their exhaled carbon dioxide. We can do that on patients that are conscious. You can see there's a picture, obviously, in chapter 18. There's another picture here on page 388 in your text that shows you a different type of capnometry sensor. And again, like the one shown in 18, this has a little fin basically that hangs down that captures the sample of exhaled air. And then one side of that nasal cannula feeds to the monitor to read. The other side of the nasal cannula is attached to an oxygen bottle to provide oxygenation. But capnometry can be a great thing. We use it in responsive and unresponsive patients, intubated or non-intubated patients. Hyper and hypocapnia, hyper meaning bigger than normal, hypo lower than normal, indicate whether their CO2 level, which typically is 35 to 45, and where they're at. So if they're having, let's say, Kussmaul respiration, they may be hypocapnic. And when they're hypocapnic, they may have a CO2 level of maybe 30, and they're having Kussmaul respirations. While they're breathing fast, they're breathing heavy, they're breathing their CO2 off very quickly. So we can also look at this picture here on the slide. We have the pleth wave of the CO2 monitoring device there. It's the yellow wave down there. You can see it marked as CO2. It's actually a very odd looking waveform there, and I imagine that it probably was bumped or moved or something. But when we look up at towards the top of the screen, there's CO2 in yellow, 33 millimeters of mercury, and 7 for an RR. So it's saying that their CO2 level is 33, so that's hypocapnic. That's lower than what we would normally expect. And their respiratory rate is only 7. All right, there again. Normal capnometry value 35 to 45. We may also choose to use something called a peak expiratory flow rate, where we're looking and measuring the maximal flow rate of air during expiration. You may or may not be using a device like this. They're not typically widespread use in EMS quite yet, but I believe it's going to increase, particularly as EMS continues to evolve and be more of an evidence-based medicine. Peak expiratory flow rate is measured by a peak flow meter, and the peak flow meter is something that kind of looks like a recorder. When I say recorder, I mean the little flute-looking thing that you had in elementary school, or not usually that long, but kind of a cylindrical device that has a mouthpiece on the end, and it has a meter or a measure on the top of it. And you will exhale forcefully through it, and it will measure how forcefully or how much air actually escaped at that time in liters per minute. Usually you'll do 2 or 3 of those, and then use the best one as your measurement. And peak flow meters, or spirometry is actually a little bit broader term, can be used to show maybe we try a peak flow meter prior to a treatment and then following a treatment. And that helps show us whether or not we have made any advances. So we have to think about it here. You're on scene with a 70-year-old male, Pete Campbell, who is working hard to breathe and has indications of hypoxia. Mrs. Campbell has informed you that her husband has COPD. As Brian opens the airway and oxygen bag, your partner introduces herself, but Mr. Campbell does not respond. She notices around his lips and accessory muscles. Notices around his lips and accessory muscle use. She quickly auscultates the patient's chest, hearing minimal air movement, and has pronounced expiratory wheezes. So what does that mean to us? That right there tells us that we need to get on the ventilation and the airway management immediately. Although he started out fine, he very quickly turned the corner on us. The patient goes unresponsive, he's cyanotic, we have no air movement, and we need to probably quickly move on to ventilating this patient. Granted, he may have some quote-unquote breathing, it's probably not sufficient or adequate. So that's going to end the part 2 of this chapter. we'll move on to part 3, which will actually be the devices.